will have some interest, they'll send questions. So I will probably say that everybody will have a chance of watching this video again on YouTube as a edited video. So we won't need to talk excessively about some like numbers like 6 ml per kg of weight or 8 ml. It's we can unless you would feel like it's necessary.
No, I mean we can go through it. It depends sort of the audience and what they really want to talk about. So that's why I wasn't sure.
Yeah, I asked a question about the availability of non-invasive ventilation in Kazakhstan. Apparently, CPAP is available. What my colleagues didn't know is who is actually managing non-invasive ventilation. Is it intensive care and intensivist, or is it for sure? I know for sure there is no such thing as a respiratory therapist.
Right.
So it's probably a physician, but I'm not sure what kind. A respirologist, an intensivist.
Okay.
That I'm not sure. So if we will get information, if we will get updates, then.
Okay. But the majority, I think, would be, if it's CPAP's not working, then you're probably going to intubation rather than BiPAP.
Right.
So and CPAP is a easier circuit and easier managed and some of this.
I asked a couple of questions concerning that dexamethasone paper, because as you see at the end, I show this so-called forest plot.
Yes.
And because this is not our forte, what I've been told is that technically speaking, the study, the trial has been done, or the analysis has been done fine. What we don't know is that they put somewhere in the methods that they excluded some patients. So there could be something like selection bias.
Yes, there is a potential for selection bias. I mean, the commentaries were actually spot on. There is some selection bias. Their threshold for starting oxygen is lower than many other people. So they many other places would probably wait till below 90%. The other interesting thing that I found in that paper was that there was also a break how long your symptoms have been gone, less than 7 days versus more than 7 days. So I think if you're more than 7 days and you need oxygen, so I think people can be more prudent like that. They also, I mean, they readily admit it was a small dose of steroids and just 6 milligrams once a day.
Yeah.
And would, the like everything medicine is more better. No one really knows. So I think people have to be cautious, and this COVID virus, it seems to take a while to get into more replication compared to, let's say, SARS and MERS. And SARS and MERS, the steroids actually were counterproductive. So I think people need to look at the patient as a whole, and, wait. That their symptoms should be more than 7 days. They should really need oxygen, and then that this may be helpful. But to give it to everybody, it actually might be deleterious. So, I think if it's a useful study. I must admit, I'm a little surprised at the results, but I think when you start, therapies need to be targeted.
But even the forest plot is showing the same. So
yeah,
it's only the patients on invasive ventilation who showed benefit.
They're the ones who really benefited the most. So.
Okay, so and other things like coagulation and what we discussed yesterday, I put.
I think it's useful to have the slide up. I don't think we need to discuss it. Yeah, to any great extent. I think we're not really here to really tell people how to manage their ICU, but
Right.
yeah.
But if we can maybe elaborate more on non-invasive ventilation, because I don't know to what extent the expertise exists, and since okay, it's a perfect opportunity, like learning opportunity for them to understand better the non-invasive ventilation, and that's why I included the pictures on the circuit. And
yeah, but I think basically. Non-invasive, you either have a dedicated CPAP device, or you could actually use a ventilator in CPAP mode. So there's a lot of flexibility, but we can talk on that.
Okay. And then just as a reminder, yesterday we said that talking like 2-3 short sentences and then making a short break so that translation can keep up.
Yeah.
So that's in 5 minutes we'll go live. So it's actually, having gone through the literature, that was interesting how incredibly heterogeneous the data are. So one publication says this, the other publication says the opposite.
In terms of?
Like one publication says that transmission and kids, don't blame the kids. Yeah. And the other publication says, well, the kids still have this inflammatory multi-organ syndrome.
Right. Yeah, exactly. So children can get sick, and children can have this multi-organ. I mean, the big question is, so I think what everyone's concerned about is transmissibility in school-age children. And there's definitely been outbreaks caused, certainly in high schools and let's say children over the age of 10. So, and so I think people have to be cautious. Like you say, the daycare, that's still, there needs to be more information. There's certainly much more adult to child spread than child to adult spread. But I mean, they still talk about, even, 8 to 10% of cases look like child to adult spread. So, and it hasn't really been looked at in daycares to any great extent. So it's not like it's zero. It does happen. And I think, especially daycare workers who are, have to touch children, change their diapers, et cetera, et cetera. There's much more opportunities to be in contact with infected secretions.
Body that's fluids, true. So. Especially given that stool.
Yeah.
It sheds with stool.
Yes. And what I'm a little disappointed with is that, all these shedding studies, there hasn't been much less, but is it active viral like live virus particles or
no, most of them, I know of one study that actually showed infectability, but most studies are just PCR. They just show that they have some RNA.
Because there was this poor mother who was, I call tortured at Saint Justin. She delivered prematurely.
Right.
She was COVID positive, but she was COVID positive for 55 days. And they wouldn't let her back in until she had 2 negative. I said, why didn't they actually do a culture? I doubt she was,
infectious.
Infectious. And yet they banned her from the hospital for 55 days. So let's say PCR positivity can last.
It's a short piece of RNA, doesn't mean anything. So I guess we'll go live in less than a minute. And as usual, there'll be greetings from our hostess, and after this, we'll take over. Okay, so I guess waiting for the signal to start. Okay, so I just received an announcement that we have a live presentation on YouTube. So I guess we can start. Okay.
Құрметті әріптестер, ханымдар мен мырзалар, Galamdyq-Sheshim COVID-19 ақпараттық арнасындағы бүгінгі шараға қатысқаныңыз үшін рахмет. Мен сіздің жүргізушіңіз Сымбат Артықбай, қоғамдық денсаулық сақтау мамандығы бойынша бірінші курс магистрантымын. Бүгін бізде әйгілі спикер Ларри Ленс, МcGill университетінің балалар пульмонологиясының профессоры, Монреаль, Канададан қонақ болып келіп отыр. Біз сондай-ақ Нұрлан Дәулетбаевтың біздің байланыстырушы буынға айналғанына қуаныштымыз. Профессор Дәулетбаев Марбург қаласындағы Филипп университетінің трансляциялық зерттеулер зертханасының директоры, МcGill университетінің және Қазақ ұлттық университетінің адъюнкт профессоры. Көрермендерге айтарым, біздің бейнеконференциямыз YouTube арнасында тікелей көрсетіледі. Ал ағылшын тілінен аударманы екінші жүргізуші a-Farabi атындағы Қазақ ұлттық университетінің медицина мамандығы бойынша бірінші курс докторанты Арина Еспатаева жасайды. Уважаемые коллеги, дамы и господа, благодарим вас за то, что присоединились к нам на сегодняшнее мероприятие в нашем информационном канале «Глобальное решение COVID-19». Я ваша ведущая Сымбат Артықбай, магистрант первого курса специальности общественное здравоохранение. Сегодня нам повезло иметь известного докладчика Ларри Ленса, профессора детской пульмонологии в университете МcGill, Монреаль, Канада. Нам также повезло, что Нурлан Дәулетбаев стал нашим связующим звеном. Профессор Дәулетбаев является директором лаборатории трансляционных исследований в университете Филиппа в Марбурге, адъюнкт-профессором в университете МcGill и Казахском национальном университете имени a-Farabi. Обращаясь к аудитории, я хотела бы напомнить, что наша видеоконференция транслируется в прямом эфире на канале YouTube, а перевод с английского будет сделан нашей второй ведущей, докторантом первого курса специальности медицина Казахского национального университета имени a-Farabi Ариной Еспатаевой. Ал келесі сөзді құрметті профессорымызге Дәулетбаев Нұрланға беремін. Я передаю слово нашему уважаемому профессору Нурлану Дәулетбаеву.
Thank you, Sumbat. Dear Professor Lenz, we would like to thank you very much for, again, providing your expertise and updating us on the clinically relevant information concerning patient management and concerning especially given the current situation in Kazakhstan. It is very much appreciated. I will introduce you again to our audience. We may have different people watching our presentation. So I will just remind myself and just for everyone, so we'll should probably talk in short sentences, and after 2-3 sentences make a short break so that there will be live translation. Okay, so and with this I will give Arina a chance to translate.
Бірінші бөліміміз ең соңғы ақпарат талқылауға арналады. Көрермендеріміздің YouTube арнасында түсініктеме түрінде сұрақтар қоюға шақырамыз. Біздің әріптестеріміз осы сұрақтарды жинап топтастырады. Сессиямыздың екінші жартысында біз қонаққа осы сұрақтарымызды қоямыз. Наша первая часть будет посвящена обсуждению самой последней информации. Мы призываем аудиторию размещать вопросы в виде комментариев на канале YouTube. Наши коллеги соберут и сгруппируют эти вопросы. Во второй половине нашей сессии мы зададим эти вопросы нашему гостю.
Thank you. I'm just, I would like to check with Arina that she is all ready to be translating because we'll be going into discussion. Okay, so she is. I hope that I can put my presentation on the screen.
I have it open as well.
Okay, so well, it worked. So this is the topic of our presentation, and just to remind our keynote speaker as well as the audience, we will have slides in 2 languages. So I will be alternating between the slides so that the audience will have a chance to fully appreciate the content. Arina? Okay, and with this, I would like to introduce our keynote speaker again. Professor Larry Lenz, he is a pediatric respirologist and an expert in genetic and rare diseases of the lung. For more than 20 years, he is director of the Division of Pediatric Respiratory Medicine at the Montreal Children's Hospital. He is a very prominent and world-renowned expert in cystic fibrosis, being director of Cystic Fibrosis Clinic and director of Neuromuscular Clinic, and he is also an attending physician of Transplant Clinic. On the research side, he chairs the research committee of Canadian Thoracic Society. And he is a full professor at McGill University in Montreal, Quebec, Canada. Professor Lenz, thank you for being with us today.
It's my pleasure to be with you.
So we have several topics to be discussed today. I would like to remind the audience that on April 30th, we had our video conference with you as keynote speaker. During that conference, we discussed a topic called COVID-19 in a pediatric patient. Today, we would like to have some follow-up because we promised this to our audience to discuss the COVID-19 cases in pediatric patients after school and daycare opening. Following this, we will move into our main topic, which is management of severe COVID-19 in adult and pediatric patients. Given that we have a very large presentation, we can probably skip on some of the topics, such as comparison between classic ARDS and COVID-19 associated ARDS, we will skip this topic. So that we can focus more on the respiratory management of severe COVID-19. If we will have questions, there'll be some question and answer period. And for the sake of the audience, I will remind again that we will have slides. Each slide is presented in 2 languages. So I would like to encourage our audience to both listen to our presentation as well as taking snapshots of the slides in either language. And if someone will miss one or the other slide, they will have a chance of rewatching this presentation as a YouTube video. Which we will post shortly after this video conference. And there will be some terminology because some of the audience may not necessarily know the specific terminology. They can be general practitioners. And for the sake of this audience, I put together this slide with various terminology. So if, Professor Lance, if you don't mind, we can talk briefly to see how things change since our last video conference on April 30th. Last time we've shown this slide to demonstrate that there isn't much data on pediatric COVID-19 cases. There are not so many cases. There are not so many published reports on COVID-19 in pediatric patients. So the comparison was that if one searches the literature, then the body of published data on adult patients looks like the planet Jupiter in comparison with the planet Earth, which is equivalent to what's the scarce data that is published on pediatric patients. So school and daycare reopening, would you like to comment on this?
Yes, so I totally agree that there is still a lack of data concerning children, both in their spectrum of disease, which we will talk about a little later, but also risk of transmission. As you can see, and maybe better put the slide up the next slide, which is translated, that various countries.
Yeah, I think she needs a moment to catch up with the translation. Okay, excellent.
Okay, so schools and for younger children, daycare centers are gradually reopening. There is been limited study of children or what is happening, but also each country and even within a country have very different practices. And so it is difficult to translate the experience from one country to another.
Okay.
For instance, in Hong Kong, both the children and the teachers are wearing a mask. There's separation in the classes, and there's been very little testing. So it is hard necessarily to translate the experience, let's say from Hong Kong to somewhere else. As Donald Trump said the other day, if you don't test, you don't find who's positive.
So just to add a comment, you think that generalization of COVID-19 knowledge is a problem, is a general problem, making the knowledge universal?
It's a problem, and that's why forums of discussion are to share experiences really very important to understand what different countries have experienced, what they have tried, which seems to work, what doesn't seem to work, because the literature is both sparse and there's always a time lag. I do want to make one other comment on this slide, because the comment is made about Germany and balancing children's safety and needs to be educated. This has been a very large problem. Where I live, it's been very variable. Some schools, particularly private schools, have maintained teaching through Zoom classes, whereas other school systems, it became very patchy and occasional, with lessons and homework being left to the whim of the child of whether it wasn't obligatory. So this would cause big problems.
I'll probably rephrase it for Arina. Professor Lenz addresses two school systems. One of them is private schools and the public schools. So private schools have the capacity of going full online, such as via Zoom, whereas with public schools, there is a problem, and sometimes they may have lessons, sometimes they may not have the lesson. And he's addressing the point that there is a great need for the children to be educated.
I just want to bring up one other point about social.
Yeah,
I'll let her finish, but then I do want to bring up about social isolation in children.
Okay.
Okay, the other important aspect that I want to bring up is social isolation, particularly in our adolescents. Their lack of direct contact with their schoolmates has been extremely difficult, with a lot of stress symptoms and depression occurring particularly in the adolescents, so they are at high risk.
Okay. So in other words, we're addressing negative consequences of not only social distancing, but also social isolation throughout the quarantine.
Yes.
What about safety?
So safety is probably the main concern. So we know that viral load in children can be as high as adults. But the larger question is transmissibility and how contagious are children. And there, the literature is mixed.
Could you give me some 1 minute because we have some technical problem?
No problem.
Thank you.
Yes, we have a slide on transmission, COVID-19 transmission and children. So once Arina will go live, she'll be able to use this slide. So the problem could be related to the fact that she is translating live on YouTube. So even if I wanted to, I couldn't translate because it's a separate streaming channel.
Okay.
We have 5-6 people here with the microphones muted, and the main audience is watching us on YouTube. But in the video that will be posted afterwards, I will just cut out this break.
Right, it is some editing.
So you can carry on.
Okay, perfect. So
Okay.
you were saying of transmission, COPD transmission.
So the bigger question is transmission, particularly how contagious are children, and looking at family studies, about 90% of the cases have been from adults to children, and about 10% are from children to adults. There have been reports of outbreaks in schools. It seems to have been more in high schools, so adolescents. Some people have suggested that there's a increased contagiousness in those who are over 10 years of age.
Mm-hmm. So they seem to be having a problem. Again,
Okay.
let me just check what's...
Проблема обратно с микрофоном. Можете дать мне 1 минуту? Перенастраивать.
So they are retesting the mic. I guess it's for the YouTube channel. Last time it was easier because everyone went online from their homes, and now we have Arena sitting in actually at the university, and it's it was supposed to be more efficient, but sometimes what's the expression? If it ain't broke, don't fix it.
So sorry again, you can carry on.
So whereas it is felt that there's a higher risk of transmission from children in those children who are above the age of 10, there are reports of outbreaks and transmission from those who are under 10. There have not been publications on daycare, but given that daycare workers are in very close contact with the children and also in contact with their secretions, both the respiratory secretions and stool, both which can have lots of virus in them, there's certainly a concern for workers in that situation.
I will probably jump in to summarize because we've been on and off. So first of all, we spoke that in children, the viral load, which is a measure of how many viruses, viral genetic material, the copy numbers, is comparable between children and adults. And the second point was that what we see from the literature is that the children above 10 years of age seem to have the highest transmission rate. Surprisingly, we do not see as many reports from daycares, preschool children. And this is surprising given that the virus can be shed with stool, with other biological secretions. And hygiene is harder to be maintained in younger children. Thank you. So should I continue with the slides? We are right now on this. I believe that the colleagues will confirm to me, I believe that the schools in Kazakhstan will reopen in September. Can somebody please confirm? Yes, okay, they're confirming that. So what would you suggest for September for?
This is a great unknown. Where I am, because my city had lots of COVID, schools were closed and will reopen in September. Whereas in other regions where I live, schools have reopened. There have been a variety of models, some with different shifts, so children coming only in the morning and another group in the afternoon, or some coming some days and other children coming other days. To date, there hasn't been a big increase in our schools, but other schools are seeing this much more in other countries, which certainly speaks to the risk of transmission within schools. Some of the decisions are being based on economic, in that if children are not in school, then typically one parent needs to stay home.
Yes. So I'll summarize again. In the part of the city of Montreal where Professor Lance lives, there have been many cases of COVID-19. Because of this, the schools, neighborhood schools in his neighborhood were closed. While schools in other regions of the city of Montreal reopened. And they have different options. They offer different options, such as part of students come in the morning, the other part come in the afternoon. So one of the biggest reasons for school reopening is the economy. Because if schools are not open, then one parent has to stay at home. Which affects the family income. Okay.
Yeah, I'll just say, in general, what is being recommended is wearing a mask in enclosed spaces like classrooms, and good hand hygiene.
Can you please tell us about manifestations of COVID-19, or rather some specifics of manifestations of COVID-19 in children as opposed to adults?
So in general, children have milder, often asymptomatic disease, or mild respiratory symptoms or gastrointestinal symptoms. However, there is a syndrome that appears linked with the infection that seems to be a multi-system inflammatory syndrome. It has been described as being like Kawasaki. Typically, these children are negative for the virus by PCR testing at the time of presentation, but have immunoglobulin evidence of prior infection.
Okay.
There has been limited reports of, while many of these children recover, there have been some deaths, but the actual therapeutic approach has not been clearly described.
Excellent. So with this, we will move on to the next topic of our discussion, which is how to define the severe form of COVID-19 in adults and children. Like you said before, each country has its own definition, so it would be important to have some sort of a generalized definition. So here's the slide, and if you can comment on, if you can please comment on these numbers and features.
So what's been most impressive with COVID-19 compared to most other viral infections is that this is hypoxia, not necessarily associated with respiratory distress. So if there is respiratory stress, there is an additional worrisome factor, but the absence of distress does not mean that this is severe disease.
Okay.
And actually, there's been many descriptions of adult patients who clinically appear to be doing better and then have a sudden deterioration, so that the patient really must be looked at in their full context. Oxygen saturation seems to be a clear marker, and generally people have been considered severe when their oxygen saturation in room air is less than or equal to 93%.
Okay.
Some people have used the ratio of arterial oxygen saturation, so that's based on a blood gas, and the percent of inspired oxygen. I do want to point out two things with this. One, if oxygen is delivered non-invasively, it is very hard to know what is the actual oxygen being delivered to the lungs.
Yes.
Okay, the other thing is, if you are doing a blood gas, is to look at the PCO2, or the partial pressure of carbon dioxide.
Which is not present on this slide.
No. Typically, these patients have a low carbon dioxide. If it is high, then this is ventilatory failure and needs some sort of ventilatory support.
And number-wise, low, high, how would you define that?
I would call a PCO2 under 45 as normal. When it's starting to go above 45, then I would start to worry, particularly in this disease. This would be worrisome.
Okay.
Okay, the other aspect is radiologically, if there is rapid development of new opacities on the X-ray, occupying 50% of the lung or more, this is again a worrisome sign and indicates severity.
So on the X-ray, if there is a rapid development of shadows, opacity means shadows, infiltrates,
Yes.
Above 50% or more of the lung, and very rapidly within 24 to 48 hours, that's also another sign of a severe COVID-19. Good. Last time we spoke about children and vulnerable children, and if this time we can talk a little bit more about the adults who are at risk for severe asthma, severe COVID-19.
So yes, there are certain associated diseases that increase the risk of severe disease, particularly cardiovascular disease, including particularly heart failure, diabetes, and obesity, and very poorly controlled asthma also seems to be a risk factor. But realize that that does not, most asthmatics do not fall into that category. Men seem to be more vulnerable than women, and that is unclear as yet. Age is a risk factor, certainly above 65, and some places above, we will say above 60. However, there clearly younger adults can have severe disease or complications, and we'll discuss about this in some upcoming slides. So whereas looking overall at who is vulnerable, this does not mean that younger adults are not at risk.
This information that we have on the slide has been gathered from retrospective studies, but we also would like to be able to predict people at risk prospectively.
Yes, and so
just a second, just for translation. Okay. In this regard, it's interesting that yesterday you and I discussed this study published in JAMA Internal Medicine.
Yes, so a group in China did come up with a predictive score, and you can see the factors listed here. It seems to have very good accuracy, which we will show. I also will mention that you can, the score is available online, so there are calculators online. So you just put in the values and it will give you the score.
So in the accuracy that you mentioned before, it's coming up on the slide.
Yes, so it has, this is called a receiver operating curve. And the diagonal line means that's the 50-50, so it's no better than chance. And this had a diagnostic accuracy of around 86 to 88%.
Okay. And that's the online tool that you mentioned.
And that's
before.
yes, exactly. That's the online tool.
So obviously this online score gives, online calculator gives a score, the higher the score, the highest the risk. So suppose we have a patient with severe case of COVID-19, or we determine prospectively that this patient is at risk. So then the question will be management, and the management also encompasses own infection safety control. It would be great if you elaborated a bit more on the infection. I will specify the reason. I've been told that in Kazakhstan there have been several outbreaks among medical personnel. So if we can emphasize the safety procedures, this infection control.
Okay, so infection control is very important. We had similar problems here in Montreal, particularly in facilities housing elderly people, especially those with chronic conditions and Alzheimer's. It is best, if at all possible, to separate hot or COVID positive patients from COVID negative patients. and you may even have a warm section, which is COVID suspect. So they are tested, and once they are negative or positive, they can be switched to being either in the hot or cold section.
Just to make sure that the translation will be correct, hot meaning COVID positive,
Positive,
cold
warm being suspect, and cold
warm
being
being suspect,
negative.
and negative is cold.
Mhm.
So it's not like you put your patients in a physically cold or physically hot.
No.
Okay. Yesterday, you mentioned something very interesting, such as refitting the existing wards or existing hospital rooms to make them negative pressure rooms.
Yes. So if possible, patients should be in negative pressure rooms. Now, even though my hospital is a new hospital, very few rooms were negative pressure, although it does run on a central air conditioning system.
Mm-hmm.
They were able to put in rooms a small plastic, what we call antechamber, or a little chamber. So with a zippered entrance, both from the this little chamber into the room, and also from this little chamber out to the corridor.
Mm-hmm.
And they were able to adjust the airflow in the room such that these rooms now became negative pressure. But I will stress that's only because we do have a central air conditioner that they were able to do this. And we were able to convert a ward of 12 rooms into a ward of 12 negative pressure rooms.
Okay.
Okay, some practical aspects related to staffing. Staff should not be on the same day, if at all possible, not looking after both COVID positive and COVID negative patients.
Mm-hmm. Okay.
They also shouldn't then all be having lunch together, which we were.
So you recommend physical separation.
Separation, so that those who are working with the infected patients should not be meeting with their colleagues working with the uninfected patients, and because everyone lowers their guard when it comes to eating. You're not wearing your mask.
Mm-hmm.
People are touching things, and so to really try and separate.
Mm-hmm. So for the sake of time, I would probably suggest that we don't go into detail in all these points, because if you can talk to us about something that I imagine Kazakhstan doesn't have sufficient expertise on, such as non-invasive ventilation, prone positioning, and stepwise approach before intubation, I think that would be most valuable.
Okay. So it's important to monitor your patients, both based on their saturation, but also on their work of breathing, which is not necessarily distress. The stress is farther on, but increased work of breathing, which you can
increased effort, yeah.
Increased effort, which you can look at use of accessory muscles. So it's not just a high respiratory rate, but it's use of accessory respiratory muscles, especially on the neck. Generally, if oxygen requirements to maintain a saturation are going up, particularly if they're going up above 3 liters per minute, then there should be consideration for use of something like CPAP, or continuous positive airway pressure, delivered by a mask. If you can avoid the need for invasive mechanical ventilation, then there should be. And so the steps generally are no oxygen, low flow oxygen, let's say 1 to 2 liters, higher flow oxygen, 3 to 4 liters per minute, then CPAP. And if CPAP is not enough, then mechanical ventilation, invasive ventilation.
I'll summarize to help with that. So what we've just heard is that it's important to observe the patient, not just measure the pulse oximetry, but also to watch the patient's breathing effort, how the patient breathes. This is not respiratory distress yet. But if a patient starts breathing involving additional muscles, such as in the neck, this is a concerning sign. And apart from this, Professor Lenz presented a potential strategy of managing the patient, going from low flow oxygen, and low flow was 1 to 2 liters, right?
Yeah.
Okay, low flow oxygen, 1 to 2 liters. Then high flow oxygen, 3 to 4 liters. Then continue with non-invasive ventilation, CPAP. With all this failing, then moving on to intubation. Did I summarize this correctly?
Yes, I just want to add, if you're seeing increased work of breathing, that would be an indication to go to CPAP early.
So bypass high flow oxygen.
Yes.
Okay. You never mentioned the prone positioning of the patient.
So prone positioning seems most helpful on those on mechanical ventilation, although it has been used on those who are on CPAP. But we're talking repeated sessions so that the total a day is very often above 12 hours a day that the patient is prone.
Okay. So we have another slide on prone positioning. Going in sessions and then having some breaks.
Yes.
For the patient to rest and then continue again.
Up to 16 hours, yes. Okay. Nerlin, I have a clinic that I have to get to soon.
We'll wrap it up. So can you mention a couple of words about non-invasive ventilation?
Yes.
And the reason I'm bringing this up is because many patients with such as COPD, they are both vulnerable for COVID-19, and the invasive ventilation works bad in those patients. It's very difficult to wean patients with COPD off of once they're intubated.
Right. So CPAP, especially introduced early, so not waiting for the patient to get tired. When you start to see increased work of breathing is the time to introduce this. You can use either nasal or full face mask. And then there's even been some people using hoods. We've even seen people using scuba diving masks, full face masks that have been adapted with a good seal to provide CPAP using either a special CPAP device or using a regular ventilator in CPAP mode.
And then just to summarize this, since you now due to go to clinic, can I propose maybe that you and I will have a separate Zoom session? I will just record it and we'll post it separately because we have a couple of extra slides for pharmacological management of these patients. And that will be an addendum to our video conference. At least we'll talk about the dexamethasone, so not to keep you up now.
Yes, that would be fine.
Okay, and then I see there are questions, and we won't have time to answer those questions because of, unfortunately, we had this technical difficulties a couple times, which slowed us down. But we can, if you would be willing, we can make a separate, just you and I, we can have a Zoom session on this.
Yes, and in terms of the questions, we can either do it with the Zoom session or we can, do it. I can send you written answers to their questions.
Fantastic. Well, thank you so much for taking time for this. I know that you're very busy, and I know that you are also managing this virtual conference. We really appreciate your time, and whatever material is still left, we'll deal with that in a separate session. So I'll just let our hostess to wrap up the session and Сымбат.
Өте қызықты және мазмұнды пікірталас үшін көп рахмет. Енді біз сұрақтар қою кезеңіне көше аламыз. Большое спасибо за эту очень интересную, информативную дискуссию. Теперь мы можем перейти к нашему периоду вопросов.
There won't be questions because Professor Lance needs to go to a clinic. So if you can, you can wrap up.
But they can, if they can write in their questions, we'll answer them.
Жарайды, кешіріңіздер. Құрметті бейнеконференция қатысушылары, біздің кездесуімізді аяқтай отырып, баяндамашы профессор Ларри Ленске конференцияға қатысқаны үшін және тақырыбындағы өзекті сұрақтарға жауап алуға мүмкіндік бергендері үшін ерекше алғыс. Біздің байланыстырып Galamdyq-Sheshim KZ YouTube каналынан көрген конференция қатысушыларына алғыс айтамыз. Біздің a-Farabi атындағы Қазақ ұлттық университетіне және Канада Қазақстан елшілігіне осы бейнеконференцияны ұйымдастыруға үлкен көмек көрсеткені үшін алғысымызды білдіремін. Модераторымыз профессор Далитбаевқа көп алғыс айтамын. Біздің әйгілі қонаққа профессор Ларри Ленске ерекше алғыс айтамыз. Сіз бүгін біздің спикер атанғанына өте қуаныштымыз. Мы хотели бы поблагодарить Казахский национальный университет имени a-Farabi и посольство Казахстана в Канаде за большую помощь в организации этой видеоконференции. Большую благодарность выражаем нашему модератору, профессору Далитбаеву. Особую благодарность хотим сказать нашему знаменитому гостю, профессору Ларри Ленсу. Мы были очень рады, что вы были нашим спикером. Біздің Galamdyq-Sheshim KZ ақпараттық каналымыз жұмысын жалғастыруда. Сұрақтарыңыз бен қызығушылық танытқан тақырыптарыңызды Galamdyq-Sheshim KZ@gmail.com поштасына жіберіңіз. Сау болыңыз және өзіңізді сақтаңыз. Уважаемые участники видеоконференции, завершая нашу встречу, позвольте еще раз поблагодарить нашего спикера, профессора Ларри Ленсона, за участие в конференции и возможность получить ответ на правильные вопросы. Благодарим участников конференции, кто был на связи и смотрит нас на YouTube-канале Galamdyq-Sheshim KZ. Наш информационный канал Galamdyq-Sheshim KZ продолжает работу. Ваши вопросы и интересующиеся темы высылайте на почту galamdyq-sheshim.kz@gmail.com. Будьте здоровы и берегите себя.
Okay, thank you so much again, and we'll have a separate session.
Okay then.
Have a great day.
Okay, bye.
Thank you, Professor. Bye-bye. Take care.
Bye.
Thank you, everyone. Thank you. Bye-bye.
So, мы еще в прямом эфире. Айна Шестенбековна.